Welcome to today's session of Women's Health, and in today's session, we're going to be looking at an important obstetric emergency known as cord prolapse. So, cord prolapse is simply the descent of the umbilical cord through the cervix alongside or ahead of the presenting part of the fetus, which can cause cord compression and also acute fetal hypoxia. So, to understand this, we just need to know that the epidemiology of this condition is about 0.1 to 0.6 in all deliveries. So it's more common in preterm deliveries, malpresentations, multiple gestation, and polyhydramnios. It's an important obstetric emergency because it puts mothers at risk for high perinatal morbidity and mortality. So to understand this condition, we need to look at the types of cord prolapse. We have got the ovate, which is also known as the complete. So in this type of presentation, the cord is visible in the vagina or it's protruding externally after rupture of membranes. We also have the occult presentation, also known as the incomplete presentation. The cord lies alongside the presenting part within the uterus and is not visible externally. We also have the phonic presentation. In this type of presentation, the cord is between the presenting part and the membranes, but before rupture of the membranes. So the clinical relevance of these types of cord prolapse is that in the complete cord prolapse or the ovate cord prolapse, it requires immediate intervention or urgent delivery. For the occult prolapse, it might be detected via the cardiotocography. So with that understanding, we just need to see what it looks like. This is a picture showing the occult presentation in the first diagram there, the first picture. The second one is the phonic presentation, and lastly is the complete or the ovate presentation. When it comes to risk factors, we have got the fetal and maternal and also the labor related risk factors. So for the fetal risk factors, we have got malpresentation, which can be a breech, transverse lie, high station, preterm, and low birth weight or multi-gestation. For the maternal risk factors, we've got multiparity, polyhydramnios, uterine anomalies. Okay, then for the labor related risk factors, we've got artificial rupture of membranes with an engaged presenting part. We've got prolonged second stage of labor and also induction of labor and also instrumental delivery. So to understand the pathophysiology, we just need to think about cord compression. So when there's cord compression, what happens? There's decreased umbilical flow, which in turn leads to fetal hypoxia, causing acidosis and putting the baby at a risk of stillbirth. Okay, so the severity of this condition depends on the degree and duration of the compression. So that's why it's an emergency, because rapid intervention is critical to prevent permanent neurological damage. When it comes to the clinical features, we can classify them into fetal and maternal clinical features. So on the fetal side, mostly we detect this presentation or via a cardiotocography, so we can see variable decelerations or prolonged bradycardia, mostly less than 110 beats per that's the fetal heart rate. Okay, for the maternal, we have got history of feeling the cord in the vagina, which is in the complete or sudden rupture of membranes. Okay, so on examination, when you're doing a vaginal examination, you may feel a pulsating cord. Okay, then the phonic presentation might be detected or via a sterile vaginal exam. So in all sense, this is also associated with meconium stained liquor due to fetal distress. Okay, when it comes to making a diagnosis, when you do a vaginal exam, you may find the presence of a cord which can be pulsating, And when it comes to clinical suspicion, there'll be an abnormal fetal heart rate on CKG, okay, or when you try to listen to it via a pin at the fetoscope, okay. So an ultrasound may detect the phrenic presentation during antenatal visits. Okay, with that being said, we're going to look at the management. So when the management for cord prolapse, firstly, we need to call for help. Okay, when we call for help, we involve the midwives, neonatal team, and also the nurses. Okay, so we need to position the patient in three prominent positions. So I'm going to show you the three prominent positions. We've got the knee chest position in the first instance. We've got the Sims lateral position, and we've got the Trendelenburg position. So when I position this patient in these three positions, so in the knee chest position, the exaggerated Sims position, just a lateral lie with a pillow under the hips. We've got the Trendelenburg position, okay, just lying on the back with the pelvis elevated. So there's manual elevation of the presenting parts. Okay, we also need to make sure that the cord is pulsating, and we do not need to reposition the cord back into the uterus. Okay. So we also need to make sure we're doing a fetal heart rate monitoring to assess the status of fetal distress. We also need to prepare a patient for O2. We need to put the patient on O2 on oxygen, just to optimize fetal oxygenation. We need to prepare anesthesia or inform the anesthetic team that we have in an obstetric emergency. We need to obtain IV access with two large bore cannulas. We need to maintain the systolic BP greater than 100, just to make sure that there is enough uterine perfusion to the fetus as well. Okay, so we also need to catheterize the patient and monitor urine output. We need to collect blood for full blood count, X match, group, and save, because this is an emergency, and we are going to immediately take in the patient for cesarean section if the cervix is not fully dilated. Okay. Well, we also need to administer about 0.9% of normal saline rapid infusion, 1 liter, while waiting for our blood products. Okay, we need to put normal saline in the bladder. Okay, the purpose of bladder feeding is just to relieve mechanical compression of the umbilical cord by the fetal presenting part, thereby maintaining fetal oxygenation. We need to discontinue oxytocin. Okay, we need to administer a tocolytic. In this case, it can be salbutamol or nifedipine. Okay, so when it comes to a delivery plan, it depends on the status of the cervix. So if the cervix is not fully dilated, the preferred method of delivery is via cesarean section. If the cervix is fully dilated and the fetal head is low in the pelvis, we need to expedite vaginal delivery using vacuum delivery or forceps. So a side note is just, if the cord is not pulsating, we need to return the mother back to labor ward for normal delivery. So we need to make sure that we are constantly doing fetal monitoring, okay, just to assess if the baby is not in fetal distress. So with that being said, due to certain things which we're going to be doing, such as the VE, and we're also inserting a catheter, we need to also put these patients on antibiotic prophylaxis after delivery, um, just to make sure that we do not have risks of them having maternal sepsis. Okay, so we also need to document all actions taken and time of diagnosis and interventions and the fetal heart rate patterns and the outcomes, just to make sure that we know what to improve on in an instance where we have another cord prolapse. We need to provide assurance to the mother and the family. We need to inform the neonatologist, just to assess the baby and the neonate promptly for any neonatal complications. We need to monitor the mother for any complications, and we need to follow up and give a review date, and also offer psychological support. Okay, so when it comes to the complications, we can classify them according to maternal and fetal complications. So maternal complications, we have got emergency Caesar related complications such as infections. Okay, and also we need to monitor the wound care. Okay, we also have psychological trauma. We also have vaginal and cervical injury during the maneuvers, and we also have fetal and neonatal complications, which we can have hypoxic ischemic encephalopathy and stillbirth if there's prolonged compression. We can also have birth injuries such as the clavicular fracture and the brachial plexus injury. Uh, and for us to prevent this condition, we can also look at our antenatal identification of high risk pregnancies such as a malpresentation, multiple gestation, polyhydramnios. We need to avoid premature rupture of membranes with an engaged presenting part. We need to continuously do intrapartum monitoring for malpresentation or abnormal fetal heart rate. So we need to also offer immediate operative delivery if the risk factors are present. So this has been a quick session on cord prolapse, and I hope we've understood one or two things. Thanks for watching and stay blessed.